Everyone, my name is Sam. I'm one of the senior biomedical scientists at Guy's and St Thomas's Hospital in blood transfusion, and I've been working in this trust for about 5 years, but I've been a BMS for over 10 years in the UK. So this is the second session that I'm presenting, and it's following on from the previous session that was a basics in blood transfusion. And today I'm going to go a bit more in depth into that pre-compatibility testing and some of the anomalies that can occur during testing. So what I'll cover today is the antigen and antibody reactions. I'm briefly going to go over the principles and the practice of ABO and RHD typing. Then I'm going to move on to some erroneous results and have a discussion on what additional testing is required and how we can resolve those. And on to antibody screening and antibody identification. And once we've done all of that testing, we can talk about pre-compatibility testing and the procedures of actually supplying blood for patients. So why is pre-compatibility testing so important in blood transfusion? So it's important for a number of reasons, because we want to ensure that we do not have an ABO incompatible red cell transfusion. This is often fatal, and prevention is the most important step in clinical transfusion practice. Any alloantibodies that are detected can cause transfusion reactions. They can also cause HDFN, and it can give us problems in selecting blood for those patients that are regularly transfused. So with the patient's pre-transfusion blood sample, we want to determine the ABO and RHD group and also test their plasma to see if they have got any red cell alloantibodies present. So although this is just an animation, it does demonstrate how complex our red cells are, just like many other cell types in our human body. So in blood transfusion, there are 9 clinically significant antigen groups that we test for, and each of these antigens have a functional role within the cell, helping with their structural integrity and transport systems. So the sample validity and requirements. So we need samples that are whole blood EDTA with all the correct demographics to perform our testing on. And for blood issue, which is the important part of sample validity requirements, if the patient has been transfused or pregnant within the last 3 months, they have a 3-day sample validity. And this is due to the potential of the patient creating an alloantibody from the previous sensitizing event of having those cells in them that are not their own. And for patients that have not had a transfusion within the last 3 months, their sample validity is 7 days. And this is because there's no risk of them creating a new alloantibody because they've not been exposed to any of those donor red cells or fetal red cells. So in blood transfusion, most of our testing is based around antigen-antibody complexes, and we use the formation of these antigen-antibody complexes to identify if the antigens or antibodies are present in the patient. So we test the known against the unknown, and much of this testing is performed now on our automated analyzers, but it's the same principle when we do this test manually. So firstly, we centrifuge our samples. This is just a quick recap of our grouping, as we require both of the red cells and the plasma. So in the grouping testing, we want to find out the patient's blood group. Therefore, we use the red cells to see what antigens are present on their surface, and this is known as their forward group, which you can see in the card is the first 4 wells. We then do a reverse group, which is to identify which antibodies are present in the plasma. So the ABO group is the only blood system in which these antibodies naturally occur. And from this, if the patient has the antigen, they will not have the antibody. So this is an example of the test being done manually. As you can see, we use the same cards. And in the forward group, the cards contain the anti-sera with the antigen that it's labelled with. So you can see the A, B, the D control. And this card is an example of direct agglutination technology, and we're looking for IgM antibodies. As the antibodies are large and work at lower temperatures, we don't need to incubate this card. So once the sample has been dispensed into the card, it can be centrifuged and we get a result. So you can see on the first picture, we've got the reagents as well that we use for our reverse group. So this is just a quick overview again about the different blood groups. So this is a diagram with the corresponding test cards of each of the 4 blood groups. So as we can see with group O, there is no antigens, so we've got no A or B on the red cell surface, and the test card below that demonstrates this because we've got negative reactions which are demonstrated by the pellet at the bottom of the card in the A and the B. And then in the reverse group, we've got very strong reactions, positive reactions because the antibodies are present in the plasma. So with the group A, they have the A antigen on their red cells and therefore react with that A well and are negative for the antibody. So that forward and reverse group match. The ABO antigens are the most prevalent on the red cell, and the antibodies are pre-formed in childhood due to exposure to bacteria that can mirror the antigen structures. Because of this, ABO incompatible transfusions is a never event and can be fatal because those antibodies are present and already very strong. So now I'm just going to go on to some examples of anomalies that we have in our lab. So if you look at this card, we can see that there are 2 distinct reactions in the forward group. So we can see a population of cells at the top and at the bottom of the reagent card. So this is demonstrating a mixed field reaction. And this occurs, as I said, when there's 2 distinct populations of red cells present in a sample, and they're both showing different agglutination patterns. So in this situation, what we should do is we should review the patient history. So could it be due to a transfusion, a BMT transplant? Are they pregnant? So could it be a maternal hemorrhage causing this dual population? So what we'd need to do is to review that patient history and document and interpret carefully to make sure we assign the correct blood group to those patients. So knowing the transfusion history, what groups they've been transfused will help you identify this. So we've got another example of a card here again. We can see that it looks a bit different to the ones that we've looked at previously with those nice clear reactions. So if you can see in this card, see if I can, we have got this control well that is positive. So this control well in a blood grouping card is used to detect those false positives due to a non-specific agglutination or abnormal red cells. So the control well should always be negative because it only contains inert gel being present. So therefore it should show no agglutination. So causes of this can include the patient having autoantibodies such as cold agglutinins or warm autoantibodies, where those red cells agglutinate everything, even without reagent being present. It could be a technical error due to the cards drying out, or sometimes it can be due to the cells being DAT positive, and those autoimmune may agglutinate spontaneously. So what we can do if this occurs, we can repeat the testing. We can wash the red cells to try and remove any autoantibodies or plasma proteins. We can get a fresh sample if we're querying contamination. We can do a DAT test to check for those autoantibodies. And we can also review the patient history to see if this has been done before. If the control is positive, the results are invalid, and until it has been resolved, we would only release universal donor products. In this instance, and we sent this sample away, and this was the report that we got back from our reference centre laboratory. So they didn't detect an alloantibody, which is good news, but they did detect a number of autoantibodies. So a pan-reactive one, which means that it caused agglutination across all the reagents. And they've also assigned an autospecificity as well. Also of note, the DAT was very strongly positive in a number of different cards. So we've got IgG, very strong, IgA, IgM at C3c and C3d, but they've got that negative control there, so they know that that result is genuine. So in this circumstance, in the laboratory, we couldn't resolve this ourselves. It had to be sent away for the reference centre to be able to perform the testing and give us a group on this patient. So moving on to RHD grouping, you either have it or you don't. And so we test for this in the same way that we do an ABO group. The RH blood group is the second most clinically significant blood group after ABO, and this is why we test for it. So this is where the positive and the negative part of the blood groups come from. And in these situations, it's therefore fine to transfuse an RHD positive patient with RHD negative blood, as they are completely lacking the antigen and therefore cannot cause an immune response. So as I mentioned, the D antigen is part of the RHD blood group system, and it's highly immunogenic. So most people are either RHD pos or RHD negative. However, some individuals have a weaker or altered forms of the D antigen. And so these can be documented as either weak or a variant D. So if you can see this card here, the previous RHD had a very, very strong at the top of the D well, but this one has got a much weaker reaction moving all the way through the gel. So if the sample comes from a lady that is under 50 years of age, we would send this away for referral testing because we'd worry about her antenatal serology depending on her being RHD positive or RHD negative. So we want to differentiate if she's a weak D, which is red cells have a reduced number of the D antigen sites, but the D antigen is normal, and we would treat this lady as RHD positive. Or if she is a variant D, where the D antigen is structurally altered, so parts of the antigen are missing and changed, therefore the patient may be able to create an allo anti-D. So in this situation, we would treat her as RHD negative. But we can't do this testing in-house, so we would identify that these results are abnormal, and depending on the patient demographics, we would either, if they were under 50 and female, send it away, or if they were over 50 and female or a male, we would just treat them as RHD positive until perhaps potentially they made an anti-D. So in this example, we've got the report here from our National Blood Service that did the testing. So she did have, she was A negative. So we're treating her as negative because she's a partial D, and she has already made an allo anti-D. So because she only had certain epitopes, she had the ability to make an allo anti-D. So moving on to our IAT testing. So the IAT test is used to detect the presence of antibody or bound complement that has been sensitized to the red cells in vitro. So in our lab tests, we use this in a number of different ways. So for our antibody screening, we use it to detect unexpected antibodies in patients or donors. In our antibody identification, we want to identify that specific antibody using a panel of red cells with known antigen profiles. We use it in our antigen typing or our phenotyping to identify specific red cell antigens using the anti-sera. We use it for compatibility and cross-matching to ensure the recipient's plasma doesn't react with the donor red cells. And we also use it in our titers and our titration, which is a process of measuring the concentration or strength of an antibody in the patient's plasma. So we would use that if we are titering to find out the concentration in case of HDFN. We want to monitor how much antibody is present in the mum. So the plasma is screened for the presence of red cell alloantibodies capable of causing a transfusion reaction in the 9 major blood groups. The reagents that we use are donor cells that are selected from suppliers, and each of these patients will have a selection of antigens that they are positive or negative for. Due to the complexity of the red cells demonstrated in the previous animation slide, they've not yet been able to supply reagents with independent antigens. Therefore, we have to do a bit of investigation to try and figure out the patterns. So to perform our antibody screening, we use the reagent red cells and the patient plasma, and this is incubated at 37 degrees, which is our body temperature, and then the cards are centrifuged. The antibody screening is used on a panel of red cells that contain examples of the clinically important blood groups most often seen in practice, and it's normally 3 cells. So you can see that on that screen that they've been grouped together into each of their families. So we have got our RH, we've got our MN&S, our Kel, these are all Kel, Lewis, Duffy, and Kidd. So they are all grouped together in their families. I've got P1 as well. So I've got an example here of a positive and negative antibody screen. So the aim of the antibody screen is to determine the presence of atypical red cells of likely clinical significance. So we want to be able to report this as it serves an alert to the clinician that there might be a delay in the supply of compatible blood. So we screen everyone and then we would do further investigation on those screens that are positive. So antibodies, alloantibodies can be stimulated by a number of different reasons. So a blood transfusion, so blood has got antigens that are not the patient's own, so they can create an alloantibody, and also fetal antigens that enter the maternal circulation during pregnancy. There are also environmental factors. So as I mentioned previously, anti-A and anti-B are naturally occurring due to the exposure to bacteria at a young age. So failure to recognise all of the antibody specificities within a sample could lead to a hemolytic transfusion reaction. So once one antibody has been identified, it's essential that the presence or absence of additional clinically significant antibodies is established. And if there's any doubt concerning the identity of any antibodies present or the ability to exclude clinically significant antibodies, a blood sample should be sent to the red cell reference laboratory. So sometimes we require 3 samples because we need to do a large amount of analysis on the plasma to identify the antibodies, as we do the work in-house and then we need to send the samples away. As the reference centre, they have access to a number of different techniques and rare reagents that we don't have in-house. And sometimes it can lead to a delay in our results for our patients because it needs to be sent away for that specialist testing. As you can see, this is 10 cells, the panel, and it's a lot more complex than the original screen. So we should be able to identify any antibodies present from that antibody antigram. So we've got 2 different types of panel that we use at my trust. As I mentioned, the reference centre have a large number of techniques that they use, but what we use in-house is our IAT panel, which is an indirect antiglobulin test panel. So the patient's plasma is incubated with panel red cells with known antigen profiles, followed by the addition of AHG, which is in the card, and this helps identify any IgG antibodies bound to the red cell. We also have a second panel that we use, which is our papain panel, which is the one below. So the top one is the IAT and the one below is our papain. So the red cells are treated with an enzyme called papain before the patient's plasma is added. And papain enhances or destroys certain antigens. It enhances reactions with our RH, Kidd and Lewis and P1 antigens, but destroys M, N, and S and the Duffy antigens. So we use this to try and help us differentiate antibodies by observing how reactivity changes after the enzyme treatment. And also it can be really helpful when there's a complex mixture of antibodies. So antibody specificity should only be assigned when the patient's plasma is reactive with at least 2 examples of red cell reagents expressing the antigen, and non-reactive with at least 2 examples of the red cell lacking the antigen. So we want to make sure that we find all the antibodies present, as failure to recognize a specificity within a sample can lead to a hemolytic transfusion reaction. In particular, the presence of anti-JK8 or anti-JKB, S, little s, and the Duffy should be excluded by cells that have homozygous expression of the relevant antigen. So homozygous expression would be, for example, this. So we have 2 copies of the FYA, and this is homozygous, so it's the strongest that antigen will be. An example of a heterozygous reaction is this one. So if you can see, it's got M and N present, therefore the M potentially could be weaker on the patient's panel. So I've got an example panel here just to go through with you and to show you how I would work out an antibody investigation. So I have scored my cards, which you can see on the right-hand side. So I've got my reactions present, and this shows me that there were positive reactions detected in these wells. So if the antigen is present, it should be positive for these wells. So the first thing I do is I highlight those lines that are positive, because I do not want to exclude any antibodies on a positive line, because there is a potential for that antibody specificity to be there. I then start working through to exclude the other antibodies there. So if you've noticed, I'm using homozygous cells, and I'm using an example of 2 to make sure that I can exclude. So I do this all the way along, and then I get to my final. So I do this for all the antigen families, and I get to my final section here. So as I mentioned earlier, I can't exclude on that M cell or the N, because that is a heterozygous reaction. So I'm going to select another cell to be able to exclude on. So I've done that there. So if you can see, there is one antibody specificity that this panel hits. So I have not been able to exclude the big C and antibody. So I've got positive reactions where I should have positive reactions, and I can also exclude all the other clinically significant antibodies, because if they were present, they should have had a positive reaction as well. I've also got lots of negatives, so it confirms that it's only that antibody present there. So I've got another example here with results, and it's showing varying reactivity with that. Once again, I go through and I highlight all of those positive lines, because I know I cannot exclude from any of those. And then I do my exclusions. So in this situation, I've been able to exclude most of the clinically significant antibodies that are present, but I've not been able to exclude KPA or my M, anti-M. So can you see in cell 6, it's got much weaker reactivity, and that is because of that heterozygous cell. So it shows you that the expression can be altered, and that's known as dosage. So that's why we don't exclude on that. So with the KPA, we can't exclude or include, because the M is also present there. So we don't know if it's just the M causing that positive reaction, or there is an underlying KPA. So in this situation, it depends on the need for antigen negative components. So anti-M requires M negative components, so we would supply those to the patient. But KPA is cross-match compatible, so we would cross-match and see if they are compatible. The majority of the units in the UK are KPA negative, so as you can see by that panel, there's only one positive cell there. So hopefully we would select a KPA negative unit. So moving on to my final panel example that I've got for you. So can you see the reactions on the right-hand side? They are all the same strength, and I've not got a single negative cell for me to be able to do my exclusions on. So there are a few reasons for this, but mainly we can't do these exclusions in-house, and we would have to send this away to a reference laboratory to try and see if there's any underlying alloantibodies present in this patient's plasma. So the explanations can include an autoantibody, and what we could do is we can absorb that off and see if there's any underlying alloantibodies in the plasma. It could be a anti-NOPS, Chido, or Rogers. So in this technique, you can actually neutralize these antibodies because they are not clinically significant. They just cause issues with our technology that we're testing with. It could be a high frequency antigen, such as anti-U, meaning a lot of the population is positive for that antigen. Therefore, it's very hard to find negative cells. So at NHSBT, our reference centre, they have rare cells that are negative for that. And finally, well, not finally, but another reason is that's come about quite recently is our daratumumab. So this is patients that are on a monoclonal antibody treatment, and daratumumab is anti-CD38. And what happens is it causes antibodies bind to the red cells, and then that affects our technology. So this can be sorted by using a different reagent type called DTT, and this doesn't have the CD38 molecule on there, but it does alter the antigen structures of other molecules. So once again, this is done off-site, and then the reference centre would tell us if we've got any underlying alloantibodies. So this is just a snapshot from the BSH guidelines, just about what, if you do detect an alloantibody, what is the recommendations for the selection of blood. So as you can see, there's quite a few that are IAT cross-match compatible. So if the patient does have a positive screen, they will always get an IAT compatible cross-match if time allows, and it's not an emergency. And many of the others have antigen negative that we need to be able to supply. So if we don't have it in-house, we would then speak to the reference centre and the national blood stocks to see if we can get those blood units on site. So this is just an example of our blood bag. So can you see for the RH, so our D, C, E, little c and C, that's printed on all bags. So we can see those negative components there. And then the additional antigen specificities that it's negative for is highlighted on that bottom line. So the one on the left is negative for K, S, and CW, and then the one on the right is K, S, JKB, and CW. So when we are selecting the blood for those patients with alloantibodies, we would be looking out for that information to make sure we select a suitable unit. So just a small bit on compatibility testing. I know I previously covered it. Just about how we do supply those units to patients. So we have emergency issues. So in the laboratory, we never deny access to blood provision, but in an emergency situation, we would provide uncross-matched blood. So we don't do any of those pre-compatibility checks that we would usually do. So because we haven't done our checks, it's a clinical decision whether this blood's required, and it should be decided on a risk-benefit ratio. Any delays to blood provision in an emergency can cause patient harm. So at our trust, we have our flying squad bloods, which are dotted around the fridges in the hospital, so that in an emergency, they can be grabbed for the clinical areas. So the next part that we have is our electronic issue, and this is sometimes known as computer cross-matching. And this is the way that most hospitals now issue the majority of their blood products. And it relies on the fact that the patient's ABO and RHD blood groups are reliably established. So they have none of those anomalies that I've previously mentioned in today's slide, and the antibody screen is negative. So the possibility of issuing incompatible units is actually negligible, but there is still a risk. The lab must follow strict criteria set out by the BSH and guidelines about the testing and result entry being fully automated, and many other recommendations. This is a mitigation for the potential of human error in the process. And also the LIMS system has the capability to make sure that there are to make sure they are selected units available in the stock. So we've got our manual serological cross-match, which I previously mentioned, and we do this by IAT testing. And traditionally, this is the final step in providing safe blood by performing a serological cross-match between the patient's plasma and a sample of red cells from the donor units. So it's performed at 37 degrees, and we're looking for evidence that a reaction which may indicate compatibility. So the IAT test is used to detect ABO and non-ABO red cell incompatibility between the donor red cells and the plasma. So finally, I just wanted to touch on another kind of testing that we do, and we sometimes use it, especially in the investigation of those anomalies that I mentioned earlier. So we've got our DAT testing, which is used to identify the in vivo coating of red blood cells with antibody or complement. So we would use this test when we're investigating hemolysis, such as autoimmune hemolytic anemia, HDFN, our hemolytic transfusion reactions, or drug-induced hemolysis. So a dilution of the patient's red cells is made, and our anti-AHG, anti-human globulin, is present in the cards. So if there's any antibodies or complement already bound to the red cells, the AHG in the cards will cause the agglutination. So we do a screen, first of all, to identify if it's positive or neg. So this contains our AHG and C3D, so detects for the intra and extravascular routes of hemolysis. And then we would perform our monospecific DAT, which is the picture below, which would help us identify which is bound to the red cells. At the reference centre, they have a lot more ability and capability to test for other markers on the red cell. So if the DAT is positive, an eluate is made from the patient's red cell, and this should be prepared and tested for the presence of specific alloantibodies. And it's not unusual for the antibody to be in the eluate, so bound to the red cell, and absent in the plasma due to the concentration being low. So as I mentioned, if we do ever have any abnormalities or testing that we can't do in-house, we often send our samples to the reference centre at NHSBT Tooting for us, and they are able to use a variety of methods and techniques to be able to understand and investigate our anomalies. So thank you.